Hello, and welcome to the iMedX Best of the Day series. We're here in San Francisco enjoying the annual hematology meeting, and it's my pleasure as co-chair, as chair of this program, to share with you a number of experts discussing with us aspects of hematology that will influence clinical practice in the months and years to come. My name is Dr. Joseph McHale. I'm a hematologist at Mayo Clinic in Arizona, and I'm delighted to be here with my friend Serge Verstovsek, who is an expert in myeloproliferative neoplasms, an area that very often the practicing hematologist and oncologist is confused about. So we're thankful that you're here with us today, and we look forward to gaining some insight from you about what is being presented here at our annual meeting and the implications that it has for our clinicians. So welcome.
Thank you for having me. Thank you for the opportunity to share the news from the annual meeting.
Excellent. Well, it's great to have you here. Now let's get right into it. Let's start with myelofibrosis. So this is a disease that for so many years, frankly, we had very little to offer patients. And with the dawn of JAK inhibitors, it really influenced how we cared for patients. Tell us a little bit more now about what is happening beyond that first wave of JAK2 inhibitors. I understand that the biology of the disease is now dictating a little bit of our therapy, and that at this meeting there have been some really important discoveries and presentations on prognostic features that will influence how we care for patients. Tell me more about that.
That's right. Our understanding of the underlying biological abnormalities in myeloproliferative neoplasms, and particularly in myelofibrosis, which is the most aggressive and most genetically complex of all the three types, is rapidly enhancing our ability to care for the patients. You may remember at the beginning of this year, New England Journal of Medicine papers reported a discovery of yet another mutation in myeloproliferative neoplasm, so-called calreticulin mutation.
Yes, indeed.
And now we know that there are three driver mutations that lead to hyperactivation or dysregulation, if you like, of a JAK-STAT pathway in myeloproliferative neoplasms. These are JAK2V617F mutation, MPL mutation, and calreticulin mutation. They are mutually exclusive, and almost all the patients would have one or the other. There is still a small proportion of the patients that don't have any. That is so-called triple negative group.
Now, so what percentage of patients are going to land in that triple negative group?
About 10 to 12% of the patients. Some say maybe 15%, but it's a minority.
So really you're saying the majority of patients now we can identify the critical mutation.
And the introduction of this testing, which is widely available here in the United States, has already improved our ability to diagnose the disease. Because remember, one of the important factors in a diagnostic process, because we don't have one test that would diagnose myelofibrosis, and fibrosis itself is not good enough, it is just part of diagnostic criteria. Now, having one of these three mutations identified in our specimens from the patients help us in many cases, to make a proper diagnosis. Now, the alternative issue is how to incorporate the knowledge about possible influence of different genetic background on the outcome of the patients, and shall we have a different therapeutic approach to patients who have a JAK2 mutation versus JAK2 versus calreticulin versus MPL, because it seems that how you get to hyperactive JAK-STAT pathway, it matters, and the outcome is different.
So what you're telling me, if I understand you correctly, is that diagnostically these three mutations help clinch the diagnosis, generally speaking. But now you're saying there may be enough of a difference between them that it might influence the therapeutic choice that you have? You wouldn't just lay on a JAK2 inhibitor for each of them?
You would. The major impact is on the timing of a referral for a bone marrow transplant, in fact.
Oh, I see. Okay.
In the past, we had prognostication done primarily on the blood cell count, age, symptoms, and that was pretty much all. We would perhaps add the transfusion requirement or cytogenetic abnormality. These are commonly used International Prognostic Scoring System or Dynamic Prognostic Scoring System, and there are several of those, but they are usually basically looking at the patient characteristics, blood cell count, symptoms, and perhaps transfusions, not on genetical component. And now, with introduction of the genetics, it may happen many times, and it's not very rare, that the patient which would be low risk by conventional prognostication, because of the genetic abnormalities, they would become high risk
And
for
so those
progression.
high-risk individuals, you might be thinking it'd be important to refer them earlier to a transplant.
Perhaps so.
Okay.
In addition to these three driver mutations, the calreticulin, the MPL, and the JAK2 V617F, in myelofibrosis, we now very well know that there are many other mutations, at last count about 26 other ones, that are mostly associated with epigenetic control of genetic expression. They are not related to the presence or absence of the driver mutations, and they may be present in patients in large numbers. What I'm talking about is clonal evolution. The patient starts with a simple disease that, through the multiple acquisitions, lead to multiple clones with different genetic abnormalities beyond the driver mutations. Now, this is not in everyday practice yet to test these patients for all these other mutations, but this brings another level of complexity to our understanding of the disease and the therapeutic planning, particularly for the transplant decision-making.
I'm glad we can call on you to remember those 26 mutations and epigenetic phenomena, because I'm sure I won't remember them. But to summarize then, we're saying that now with these three mutations, diagnostically they help us find the diagnosis. They may differentiate prognostic features that historically may not be captured by our routine prognostic measures. And obviously in the future we'll be looking to epigenetic phenomenon. Let's think a little bit further now. Are there things beyond the typical JAK2 inhibitors that we can learn from this meeting that are going to start influencing the way we care for patients with myelofibrosis?
The field is moving in two directions. One would be to add another medication that make mechanistically perhaps sense to combine with the JAK inhibitors. All the JAK inhibitors that were tested so far in the clinic, there were 10 of them. And one has been approved and two are in a phase 3 approval studies. They all inhibit the ATP binding to a JAK2 enzyme, prevent the energy source to bind to enzyme, so they inhibit the JAK and the JAK-STAT pathway doesn't work.
Okay.
Now there are other intracellular signaling pathways that may contribute to the disease persistence or progression. PI3 kinase inhibitors are being combined with the JAK inhibitors. We have oral session that will include the talk on that. There is a Hedgehog inhibitor combination with the JAK inhibitor. There is also histone deacetylase inhibitor combination because of epigenetic abnormalities that we mentioned. And other newer agents, antifibrotic medications in particular, that target fibrosis itself, are being combined with JAK inhibitors. All of these combinations with the goal to bring additional benefits, improving the anemia in particular, because JAK2 inhibitors by and large don't improve the blood cell count. They improve the symptoms and the spleen, but the blood cell count can even go down, not up in most of the patients. So with antifibrotic medications, perhaps if fibrosis diminishes, maybe the count will come up. Or with the histone deacetylase inhibitor, you may have a bone marrow change, improving the blood cell count. So bringing additional agents that make sense to combine, and there is no overlapping toxicity, with available JAK inhibitors for additional benefits, bone marrow change, fibrosis change, blood cell count improvement.
So in all of these ones you're talking about, the PI3 kinase inhibitors, the HDAC inhibitors, the antifibrotics, all being now combined with JAK inhibitors, so JAK2 inhibitors, so JAK2 inhibitors plus. Are there one or two here that are at the top of that list that you think might be able to make it to the clinic in the near future, or are we still looking years ahead?
I think we are still looking a little bit ahead because these are really early preliminary results. There are actually 8 different combinations that are presented this year, and there was none last year. So we are actually making a progress in our abilities to identify possible combinations, and we are engaged in broad spectrum studies across the continents, Australia, Europe, United States. A lot of studies are going on. We will see which one will be the best, but certainly there is a room for improvement with the combinations.
Sure, it makes a lot of sense. You know, as you say, if the JAK2 inhibitors really focus on spleen and symptoms, it would be nice to have a partner that can help with the cytopenia side of myelofibrosis. Well, before we leave the topic of myelofibrosis, we've talked about JAK2 inhibitors. We've talked, of course, about the biological underpinnings of this disease. And now you've mentioned to me a number of JAK2 inhibitor partners. Is there anything utterly and completely new that we might be seeing down the way that may influence the way we care for patients with myelofibrosis?
There are attempts to do something different. You are right. We have a backbone of a JAK inhibitors where we can now add medications. We talk about the genetics maybe influencing what we do transplant-wise, and I should say that it seems that the genetic complexity does not influence a response to the JAK inhibitors. They work well in all types of patients, regardless. But of course, we would like to do better. So why not, for example, think about selective inhibitors of different JAK family members? If the known JAK inhibitors inhibit the JAK2, which is important for proliferation of the cells and for inflammation, why not develop JAK1 inhibitor specifically, which would be more of anti-inflammatory, perhaps less of myelosuppressive? And indeed, Dr. Mascarenhas from New York is presenting us final results of the phase 2 study of a specific JAK1 inhibitor at this meeting. And preliminary results that are in the abstract book tells us that it is very good medication for symptoms, but it is less actually effective on the spleen because it is less of anti-proliferative medications. So that was one aspect of possibly improving or modifying what we do. But there are other targets, you're right. One of them is telomerase inhibitor that has been presented last year, and now in a follow-up we see more patients treated with this medication. The idea here is to affect the endings of the chromosomes that need to be salvaged when the cell divides with the enzyme which is telomerase. And the telomerase inhibitors would prevent that so that the cells would die off. And I would not say the first time ever, but rarely that we see enthusiasm about the agent like this one, where there is a possibility in selected patients so far, a small percentage of the patients that have been treated, but nevertheless, there is a notion that several patients achieved complete response even, which would mean normalization of the bone marrow environment, elimination of fibrosis, and improvements of the blood cell count.
Well, that would be a tremendous
That would be something. We'll have to see the update at the actual meeting. There were some safety issues. The drug is myelosuppressive. There were some safety issues related to the liver toxicity, but it is very intriguing result, which we will follow closely.
So it sounds like, again, not quite ready for prime time yet, but we could have this JAK1 inhibitor, or maybe knowing the right JAK, as it were, to inhibit. Right. But then furthermore, this telomerase inhibitor may be something to watch for. That's great. Well, thank you. Let's turn our focus a little bit. I know we love to talk about myelofibrosis, but there are other aspects of myeloproliferative neoplasms, namely polycythemia and essential thrombocytosis. Let's turn to polycythemia. You know, this has been the big news of this last week, that a JAK2 inhibitor has been approved for second-line therapy for polycythemia, even prior to the meeting commencing, right in sync with the meeting commencing.
That's right, 2 days ago.
Just tell us a little bit about that for those who may not be familiar with exactly the indication that the approval was granted.
You see, we don't really hear much about PV. You're right. That's kind of benign disease. Many consider this just the chronic condition that you live with forever and nothing to do about it, just phlebotomy, aspirin, maybe hydroxyurea. And that's very well established practice.
And no leeches anymore.
No
right?
leeches anymore. Okay, good. People are afraid of the leeches, so we don't do that. So we like pills. But not everybody does well, actually. You know, standard practice is for patients that have a history of blood clot or are older than 60 to give them hydroxyurea as a front line, to eliminate a need for phlebotomy, and maintain the hematocrit below 45 to decrease the risk of thrombosis, which is the regular goal of therapy. Not to eliminate disease, but to decrease the risk of complications from too many red blood cells in particular. Now, patients that don't do well on Hydrea, and that is about 20 to 25% of these patients.
So a significant proportion.
It is actually a significant proportion of the patients, and it's not trivial, because there are about 120, 150 thousands of people living with PV in the United States. So if we do a little math, that is probably about 20,000 people that are in need of cytoreductive therapy and don't do well on Hydrea. So ruxolitinib as a JAK inhibitor was tested in a randomized study, which led to its approval 2 days ago for patients that are specifically resistant or intolerant or not responding anymore to hydroxyurea. So strictly second-line therapy in these patients that are in need of something new. And you know, a retrospective analysis showed that these patients really don't do well. They have a high risk of transformation to acute leukemia and also shorter survival on its own, because uncontrolled disease leads to complications. And now we have officially approved, in fact, first time ever, a therapy for PV in a second line.
Well, that's excellent. That's encouraging, obviously, for patients, especially in that subset, as you've mentioned, who are unresponsive to hydroxyurea. Is there anything being presented here at the meeting in light of that approval of ruxolitinib for polycythemia that might be of interest to the clinician?
Yes, there is a presentation from Dr. Ruben Mesa from Scottsdale, Mayo Clinic, on one aspect that we always forget, or many times forget in myeloproliferative neoplasms, and that's this quality of life issue. You know, we are preoccupied with the numbers, and that's with a good reason, because numbers and hematocrit in PV is correlated with the thrombotic risk. So spleen may be enlarged, we want to shrink it, we want to decrease the high white cell count, we want to decrease the high platelets. The field has moved in myeloproliferative neoplasms with a good reason to recognize how quality of life of these patients is very bad. And JAK inhibitors across the board have been very good in improving that quality of life. So what happened in the study, the phase 3 study that led to ruxolitinib approval, is that we specifically looked not just at the spleen reduction, decrease in white cells, platelets, and red blood cells, but also significantly analyzed in detail the quality of life improvements. And across the board, many of itching, night sweating, low-grade fevers, bone aches and pains, this is in majority of the patients. I'm talking about 90 to 95% of the patients significantly improving the quality of life.
That's excellent. Well, you know, you myeloproliferative neoplasm physicians have actually been a real example to all of us in malignant hematology of being able to capture quality of life with measures that are accurate and that are reproducible. So it's encouraging to know that with those metrics that you're not only seeing the improvement in the so-called objective measures, but now in quality of life. Well, before we close off, why don't we turn finally to ET. Again, another aspect of myeloproliferative neoplasms that's not often thought of. Often a lot of patients can just be cared for with a little bit of aspirin and an occasional platelet check. Anything new from the meeting on essential thrombocytosis?
The ET, or essential thrombocythemia, is considered really the most benign. I mean, the life expectancy is close to normal. There are good therapies, hydroxyurea, anagrelide, interferon can be also used. Interferon can be also used in polycythemia vera. And we should probably say also about the long-acting interferons that are being tested in PV as well. In addition to the pegylated ones, these are the long ones that are given once a week or every other week even. In polycythemia vera patients, and they were studied in ET as well. So at this meeting, to go back just to, for a moment to the PV, Dr. Kilajian from France is going to tell us long-term experience with his study in PV with the long-acting pegylated interferon called Pegasus, and whether genetic abnormalities, which we discussed, influence the outcome of the patients treated with interferon. We know that the genetic abnormalities do not interfere with ruxolitinib therapy in myofibrosis, but he has a lot of experience in PV with pegylated interferon, and that will be interesting. You see, the interferon obviously is a biological agent. Does the biology of the disease in a given person affects the biological therapy? We'll see. In ET, there is a little bit less of activity because of how patients are in clinical practice covered. They are covered very well. However, there is a poster with the JAK inhibitor, the same one that we've mentioned, the ruxolitinib, a long-term experience in about 34 patients, and it can decrease the platelets, but at the same time, it does decrease to some degree red blood cell count. So we have kind of a mixed bag. It can decrease the platelets, but we don't want any anemia to happen. So we have a decent response in about 70 to 80% of the patients, but it's not as tremendous as in PV.
Are those in sort of the higher risk patients that are considered to be more resistant to regular therapies? Okay.
These are the same ones. We always start with the patients that are in major need of therapy, so patients that did not do well on hydroxyurea or anagrelide, the second line or the third line therapy. But the activity is there, perhaps not ready yet for full exploration for future studies like phase 3 studies.
Well, thank you. This has been excellent, tremendously informative. We trust that you've enjoyed our session on myeloproliferative neoplasms. We now have phase 3 study validating an FDA-approved agent now for polycythemia. We've learned a little bit about some of the biology behind myelofibrosis and maybe some novel agents that will come and influence the way we treat patients with myelofibrosis. So thank you, Dr. V, for your time with us today. We appreciate it very much, and we look forward to working with you again.
It was a great pleasure. Thank you for having me. Thank you.
Pleasure.